Most headaches in pregnancy are benign, for example migraine or tension-type headache, but the pregnant woman is at risk of life-threatening secondary headaches. Failure to consider and recognize potentially devastating conditions leads to significant morbidity and mortality. Neurological conditions are one of the main causes of maternal death, so obstetricians must be aware of these conditions. A sixth nerve palsy presents with binocular horizontal diplopia with interning of the eye and decreased lateral movement. Look for pinkness of the disc with blurring and heaping up of its margins. Pregnancy can alter migraine aura and trigger attacks of aura without headache as a result of high plasma concentrations of estrogen. Women may present with aura for the first time in pregnancy, leading to concern regarding intracranial disease. 5-HT1 receptor agonists, triptans, are commonly used and effective. Sumatriptan is the most extensively studied of the triptans during pregnancy. Propranolol, 10 to 40 mg 3 times a day, has the best evidence of safety in pregnancy and lactation. Women who experience migraines have a more than twofold increased risk of preeclampsia compared with women who do not. Presence of vasogenic brain edema, presence, is caused by a breakdown of the normal blood-brain barrier. Cerebral blood flow is maintained despite changes in blood pressure by an autoregulatory mechanism facilitated by changes in vascular resistance. Edema leads to progressive brain compression within the skull and the symptoms of headache, nausea, vomiting and seizures. Infarcts and hemorrhages are relatively uncommon but occur in approximately 15% of cases. Presence can also be associated with immunosuppressant drug use, nephrotic states, sepsis and systemic lupus erythematosus. Pregnancy is a recognized risk factor for the uncommon but catastrophic event of cerebral venous thrombosis, CVT. CVT may occur as a result of prothrombotic changes and dehydration. Caesarean section, systemic infection, vomiting and anemia increase the risk. The greatest risk period is the third trimester and the first 4 weeks postpartum. Magnetic resonance imaging with T2-weighted imaging and magnetic resonance venography, MRV, is the imaging modality of choice. Treatment, usually anticoagulation with low molecular weight heparin, should be continued typically for 6 months. CVT is not a contraindication for future pregnancies, but women should be counseled that they are at risk of further venous thrombotic events. Many women experience headaches during pregnancy and the postpartum period, and most are managed by the women themselves or within primary care. Doctors need to be aware of the symptoms, signs and appropriate response to the rarer and more severe causes of headache that continue to cause avoidable morbidity and mortality.